Good morning, everybody. My name is Jacqueline Tamis-Holland, and I'm an interventional cardiologist at Mount Sinai Morningside and the moderator for the late-breaking science sessions, New Drugs and New Indications in Cardiovascular Disease. This morning, I'll be interviewing our researcher, Dr. Jane Armitage from the University of Oxford in the United Kingdom. She'll be talking about the results of the ASCEND Dementia Cognitive Function Study. Welcome, Dr. Armitage.
Thank you.
So can you give us a little bit of background regarding the actual main ASCEND study and the sort of thought process behind doing the ASCEND Dementia study?
Yes, of course. Thank you. ASCEND was initially designed to test the hypothesis that aspirin, low-dose aspirin daily, in people with diabetes who'd not yet had any cardiovascular disease, whether or not the benefits of aspirin by protecting against heart attacks or ischemic strokes would outweigh the risks due to excess bleeding. And we randomized 15,500 adults with either type of diabetes and followed them for 7.5 years. And the main results of the trial were reported in 2018. And overall, we showed a 12% reduction in serious occlusive vascular events, but we saw about a 30% increase in the risk of bleeding. And our overall conclusions that it wasn't clear that the benefits of aspirin substantially outweighed the risks due to the excess bleeding. But of course, doing a long-term study like that gave us the opportunity to address other questions. And there has been real uncertainty about whether or not aspirin might be beneficial or indeed possibly harmful on the risk for dementia. So it might well be beneficial by preventing transient ischemic attacks or ischemic strokes, but it could be harmful if it were to increase the risk of either major bleeds in the brain or even what they call microbleeds in the brain. So there was uncertainty, and so what we've done is followed the patients for a little bit longer. So the original scheduled treatment period when they were on their aspirin or placebo lasted 7.5 years. And we've got a further 1.8 years of follow-up. And the reason for doing that was because sometimes dementia takes longer to emerge. But what we were also able to do is to link all our participants to the centralized National Health Service electronic records. So that meant that if any participant in the trial was admitted to hospital, we would get information about the causes of those admissions, including cases of dementia. For this particular analysis, we don't have access to primary care, that's GP records, but we had information both during the trial from themselves, sometimes from their carers, and sometimes from their doctors. So in this analysis, we've got a total of about 1,150 total cases of dementia that have emerged, that's incident cases that have emerged since randomization in these 15,500 patients.
All right, great. It sounds like an incredible study, and I really congratulate you on the way in which you orchestrated this trial. Can you tell us a little bit more about the results of the trial and what you found with respect to aspirin use and the impact on cognitive function?
Yes, so we defined two definitions, if you like, of dementia. One, a broad definition, and that was to try and capture anybody who might have dementia, even though it wasn't actually recorded as such. So those were, we called that the broad dementia outcome, and it included reports of dementia, confusion, cognitive impairment, referral to a memory clinic, or referral onto a geriatric psychiatry. And that was our primary outcome for this analysis, which we pre-specified. And as you can see now on the slide, we saw 548 reports of that broad dementia outcome among those allocated aspirin and 598 among those allocated placebo. So that gave us a risk reduction of 9%, which was not statistically significant, but our confidence intervals around that result go from a possible 19% benefit to a possible 2% hazard. So not on its own statistically significant, but also reassuringly not suggesting significant harm. We also pre-specified as a secondary endpoint a narrower definition of dementia. And that, as you can see on the screen, there were fewer cases in that case, so 254 or 3.3% versus 283, 3.7%, giving us a similar hazard ratio of 0.89 or an 11% non-significant reduction in the risk of dementia.
Well, Dr. Armitage, this is really interesting results. I would almost want to say slightly almost disappointing because it just falls so close to showing a benefit, but yet it doesn't reach statistical significance. What is your impression of these results in terms of what you'll tell your patients, or whether you think this should inform future studies?
Well, certainly, I think if we were able to have studies with more cases of dementia, we have a better chance of being able to demonstrate whether or not this is a real benefit or not. We will continue following these particular participants because we're able to do that through their electronic patient records. And we had pre-specified that we would do that 5 years after the end of the randomized comparison. So there will be more information emerging. I agree, it is slightly disappointing, but given how widely aspirin is already being used in this primary prevention population, despite the results which are not overwhelmingly in favor of using aspirin, but it is still very widely used. And I think it is therefore reassuring that we see little evidence that there's any harms with, the confidence interval going up to about the possibility of a 2% harm. So when we did cognitive function testing in the survivors and among the people who we were able to get a cognitive function test at the end of the study, we were not able to demonstrate any difference either. But interestingly, when we used the trial data observationally, so not taking into account the randomization, we were able to demonstrate that heart attacks and strokes were associated with an increased future risk of dementia, whereas by contrast, arterial revascularization was not associated with any future risk of dementia. So I think these are also valuable results from this particular study.
That's actually really interesting. Have you done any analysis regarding one's risk of dementia and the relative benefit of the aspirin beyond that? Like you said, the event rate might have been low if you had a person with a higher chance for dementia.
We can look at how many events we've avoided, so ischemic strokes, TIAs, and make an estimate of how much that might translate into benefit, but it's quite small. And in fact, the effect that we see on dementia is somewhat larger. But we will, explore this data in more detail, and we hope to have a publication out in the near future.
I'd like to congratulate you again on really outstanding work, and thank you so much for taking the time to talk to us today.